This is a follow-up video to the migraine types. We've talked about these top ones, and then we're going to go over roughly 12. But first I want to go over the others to consider: thunderclap, neuralgias, and TMJ. And you might have caught it. The top is primary. So I want to finish all the primaries before going into secondary type headaches. The treatments for primaries are all kind of the same, and then secondaries is mostly dealing with that secondary cause. There's no particular treatment, it's just getting rid of the cause. So others to consider, we've got thunderclap, neuralgias, and TMJ. Thunderclap I always thought of as synonymous with subarachnoid hemorrhage. So that's where this rule out vascular issues comes in. But if you're being seen in a neurology outpatient setting, they've already ruled out these things. So they've done a CT scan, they don't see a subarachnoid hemorrhage. Although you might need an MRI for smaller aneurysms. Subarachnoid hemorrhage is just the result of a bleeding aneurysm, right? And there's also vasoconstrictive syndrome, which happens in pregnancy, and pituitary apoplexy postpartum. There's lots of different ways to categorize migraines. So some people will just categorize these as pregnancy migraines, but thunderclap is describing that very intense, all of a sudden migraine. So the treatments for something like this is beta blockers, calcium channel blockers, Topamax, and lithium. All of these we've seen before. Even the calcium channel blockers, which supposedly is unique to cluster headaches, you can use in thunderclap. Lithium is the first time that I came across lithium as a treatment for migraines when I was learning about thunderclap. And who knows why they decided to use this, other than they were like, oh my gosh, this person's crazy, let's try some lithium. But I guess it seems to work. Triptans and indomethacin you can use for as needed, but typically these headaches and migraines are so quick that as needed medicine isn't very effective. And just to go back real quick, ice pick headaches are going to be very similar to thunderclap headaches, and they might be one and the same. But also gabapentin is an option here, and COX-2 inhibitors and indomethacin. And ice pick headache is more commonly now in the textbooks referred to as primary stabbing headache. It sounds more legitimate that way. So then there's neuralgias: trigeminal neuralgia, trigeminal autonomic cephalalgias, and occipital neuralgia. You've probably heard of trigeminal neuralgia. Some people call this the suicide disease because it's so intense and so horrible that people will kill themselves. So the only difference or distinction between trigeminal and trigeminal autonomic cephalalgias, which you probably haven't heard of, is that trigeminal neuralgia has a refractory period. Trigeminal neuralgia was first described to me as people that complain of pain while brushing their hair. I've heard of so many patients complain of pain while brushing their hair, and oftentimes has nothing to do with trigeminal neuralgia. But interestingly, trigeminal neuralgia, while it will be very touchy, it's like that nerve can only depolarize so much. There's a picture over here of the 3 branches of the trigeminal nerve going to the forehead and the sinuses and then the jaw. And most 90% of people with trigeminal neuralgia, it'll be branches V2 and V3, the maxillary and mandibular. But very less than 10% of people with true trigeminal neuralgia will have it on V1. But if you can get them in an active episode and you push on that nerve, yes, it will be tender, but it won't activate the pain, because right after. So when you see these patients in the emergency room, they will sometimes literally be holding their head and in an active attack that only lasts a few seconds. And then after that, you can actually push on the nerve and it won't reactivate. Whereas in trigeminal autonomic cephalalgias, it will depolarize that nerve and activate that pain. Also in the ER, sometimes we'd put these patients, we'd put ice on their head, or you could put your head in an ice bucket and it'll make things feel better. Because cold makes it harder for nerves to depolarize. The unique treatment for trigeminal neuralgia is carbamazepine and oxcarbazepine. Oxcarbazepine has less side effects, but for whatever reason seems to be less effective for trigeminal neuralgia. There's also lamotriptyline, Topamax, valproic acid, and gabapentin. Then there's trigeminal autonomic cephalalgias. There's 4 of these, 2 of which we've already talked about. So the 2 that we've already talked about are cluster headache and hemicrania continua. These can happen at any branch of the trigeminal nerve, but they tend to be unilateral. Same with trigeminal neuralgia, it tends to be on one side or the other. But we already know that the hemicrania continua we treated with indomethacin, and same with the paroxysmal hemicrania. They both are indomethacin, and I know you hate using indomethacin because it's a liquid, but you got to do it. In neurology, you are going to be prescribing indomethacin. It's 25 milligrams per milliliter, and about 50 will do it. So they'll need about 2 milliliters, just a very small spoon of indomethacin. With the paroxysmal hemicrania being exactly what it sounds like, it's just that half of the face pain, but instead of it being continuous, like in hemicrania continua, that lasts 3 months, it's very briefly lasting. So just a couple seconds, and then it'll happen roughly like 200 times a day, sometimes 600 times a day. They'll be having pain, and if you push on that nerve, it will create that pain. No matter how many times you push on that nerve, it'll keep depolarizing. So that's the difference between these TACs and TGN. Alternatives to indomethacin, if they can't have it because they have one kidney or whatever contraindication, you could use melatonin, which is similar in structure to indomethacin. That would be a 10 milligram dose, or Topamax. Although those would be second line, not first line. So you got to use indomethacin. Then we've got our cluster headache, which we already talked about. And verapamil, for a lot of textbooks, is still listed as first line, although I prefer Emgality. Both of those are preventative options. Whereas indomethacin is an as-needed option. And part of the reason it's good to have these alternatives is because it's hard to keep taking indomethacin depending on how often they are having these TACs. If they're having them every day, you can't really take indomethacin. I mean, you could, but it's going to be bad for your kidneys and your GI system. So then you could just take a nightly melatonin or Topamax. They are more so like preventative types. Verapamil and Emgality are the 2 approved preventatives for trigeminal or cluster headaches, and then the other options, just to be thorough, are Topamax, valproic acid, lithium, and indomethacin. So as you can see, lithium is also available for this as well. So I wouldn't get too hung up on these types. I'm going through these types so you're aware of them, you've heard of them, you don't feel stupid when someone brings them up. But I'm going to go through the treatment option in the next video that will hopefully just make all this so much easier. And then you've got the SUNCT or SUNA migraines, and that stands for SUNCT is short-lasting unilateral neuralgiform headache with conjunctival injection and tearing. SUNA is short-lasting unilateral neuralgiform headache with autonomic symptoms. So SUNCT presents with both conjunctival injection and tearing, whereas SUNA presents with other autonomic features and can include either conjunctival injection or tearing, but not both. So who cares, right? That's just, it's pain, and it is treated with lamotrigine, which isn't unique. Other things in the headache world, in migraine world, are also treated with lamotrigine. Occipital neuralgia is pain with the occipital nerve. These are the 3 branches. You've got the lesser occipital nerve, greater occipital nerve, third occipital nerve. The treatments would be a nerve block, usually a GON, a greater occipital nerve block. There are secondary causes for this, herpes zoster and neoplasm, so you always want to be kind of thinking about secondary causes, especially with these more rare types of head pains, which is why MRI with and without contrast is going to be a mainstay of neurology practice. So back to, we got through that, all the weirdo primary types. Let's get into the rest of these secondaries. So we got sinus headache. I also wouldn't get too attached to these drawings of where these present. So sinus headache, of course, is going to be at the sinuses. And because of this one entity, it is perfectly reasonable for you as a neurology specialist to prescribe fluticasone or Flonase just to rule this out. However, it's actually more common for people to call a sinus headache or mistakenly call it a sinus headache just because they have head pain in their sinus area or in their maxillary area. when it's not a sinus headache at all. These head pains can cause nasal draining too, which makes people think, oh, it must be allergies. But a lot of times it's not. But you can't know that until you treat those allergies. So Flonase is super safe, except for you want to be careful in children. There's some evidence it might stunt growth, so you want to be careful. But give them fluticasone just to rule things out. Hypertension and caffeine, of course, you want to eliminate the caffeine, treat the hypertension, but you can treat it the same as a tension headache. And medication overuse to stop the offending agent. Common agents are oral contraceptive pills, stimulants like Adderall, SSRIs. Of course, these affect serotonin, and we know serotonin is related to migraines, and then others as well. Wellbutrin is another one that doesn't affect serotonin. It's an NDRI, or norepinephrine dopamine receptor inhibitor, but it causes a lot of headaches. So just look at that medication list. Post-concussion, the only medication studied in post-concussion syndrome is amitriptyline. It does seem to be effective. Post-concussion headaches typically resolve in 6 months to a year, but then some people can just convert into a headache person after that time. If they're not gone after a year of the concussion, then they may just now be a headache person. I didn't have a picture of where it would be on the head for this because it could be anywhere. It could be where the injury occurred, or sometimes it can be somewhere else. Hormonal, another word for this can be catamenial if you're talking about during the time of the month, but other times it can be from menopause. Although you do want to be very wary about people that are older and just now getting migraines. So even if you've got a menopausal woman, I would still strongly consider an MRI if they have no history of migraines. If they had catamenial migraines before and then they're going through menopause or had a hysterectomy and now they're having more migraines, that tracks. But if they've never had migraines and now they are, then you want to be careful about that. But you just want to wait out those menopausal migraines. You could also use the same standard treatments or just wait. Spinal headaches, you can use a blood patch. These get better when you lay down, worse when you stand up because of the pressure changes. And I put all three of these at the bottom because really the best thing for all three of these is time. With post-concussion, hormonal, and spinal headaches, you want to wait those out. Hormonal in the menopausal person, also in the transgender person, if they've just started estrogen and now have migraines, their body should adjust over time, but they may just end up being a chronic migraine person, at which point they have to decide which is more important, their estrogen or the migraines, which, all the same treatment would be reasonable. I went ahead and highlighted some uniqueness to these. The verapamil for cluster headaches is somewhat unique. Indomethacin for hemicrania continua is somewhat unique. Gabapentin for the ice pick or primary stabbing headaches, kind of unique. Also, melatonin can be used for cluster and ice pick. But pretty much all the things that treat all of these can be used for any of these. Other secondary causes of headaches, just to be thorough, there's Chiari, which tends to be head pain related to coughing. Giant cell arteritis, which if they've gotten to you at outpatient, it's probably too late. These patients have a high chance of going blind if not treated early, so you want to start steroids right away. Idiopathic intracranial hypertension or pseudotumor cerebri. I misspelled cerebri, sorry. This is hard because it's a lot of the same people that present with migraines. It's the women of reproductive age, women in their 20s and 30s, but also tend to be overweight in this specific population. So that's where I'm not going to get into it too much for the sake of this video. There's nummular headaches, which can be primary. Nummular describes a circular area on the head, and it's always in that same exact place. But you want to be very careful about this one and always just assume it's secondary, or basically assume it's a tumor before you decide it's a nummular headache. There's press posterior reversible encephalopathy syndrome, cardiac cephalalgias, and pregnancy headaches, which we touched on earlier. But I won't go into all of those. A lot of this information came from the only neurology book you'll ever need, if you want to read that. And that's the end of this video.